Hi, everyone. My name is Dr. Stephanie Weyrauch. I'm a physical therapist at Physical Therapy and Sports Medicine Centers. And today I'm going to talk to you about a talk called Mind Over Bladder, where we'll be focusing on the pelvic floor and on incontinence issues. So let me bring up my talk here. Okay. And make sure that you can see my mouse. All right, so like I said, I work at Physical Therapy and Sports Medicine Centers. And today we're going to talk about the pelvic floor, specifically when it comes to something that we call incontinence, which I will describe what that is later on in the talk. We have 31 locations around the state. So if you are looking to see a physical therapist for a condition, we treat all kinds of conditions. We have lots of locations that you can choose from. I'm located in Orange, which is close to the JCC. Our goal and our mission at Physical Therapy and Sports Medicine Centers is to improve the quality of people's lives by providing unmatched experiences, clinical excellence, and we love to promote and build lifelong relationships with our patients. I'm one of, I think, 5 pelvic floor specialists within our company, but we, like I said, we do have pelvic floor physical therapists located around the state. These are some of the conditions that we treat. So we treat more than just injuries. We also treat women who are pre and postpartum. And you know, the postpartum period can last all the way 20 years after you have a baby. I have lots of patients that come in and they say, I wish I would have known about this pelvic floor PT thing 10 years sooner, but just know it's never too late to see a pelvic floor physical therapist. And this is me. This is where we're located. So let's talk about what types of conditions, when you were talking about the pelvic floor, that can be treated with by a physical therapist. So the first one is pelvic organ prolapse. And a lot of times people will describe these symptoms as heaviness within the vaginal area or in the abdominal area. Stress and urge incontinence, which are 2 different kinds of ways that the urine is lost, which we'll talk about the difference between those in the talk. Pre and postnatal care. So making sure that during pregnancy, women are getting ready for birth. It's a common misconception that we should be pushing our babies out when really the goal is to help relax the pelvic floor muscles. And those muscles have to stretch over 300 times their normal length during birth. So we teach people how to relax those muscles and how to prepare for birth. We'll treat painful conditions that can occur when a person is pregnant. And then we can also treat people after they've had their baby, whether they've had a C-section or a vaginal birth. Diastasis recti is the separation of the abdominal muscles, which is a common complication post-birth. We treat pelvic pain and vaginismus, which is pain within the vaginal area. Urinary incontinence is a very common condition throughout the United States. 25 million Americans suffer from it. And probably most of the, especially women that you know, have had experience with this at some point in their lives. And it is a common condition that can happen postpartum, but just because something is common doesn't mean that you have to suffer with it. There are interventions that can help you. 1 in 4 women over 18 years of age experience episodes of involuntary urinary leakage or incontinence. And the most common form is stress incontinence. Stress incontinence is when pressure is applied to the pelvic floor, like a cough or a sneeze or a jump, and the muscles can't necessarily hold the urine in, and so the little bit of leakage comes out. It's twice as common in women, but it can happen in men. And the primary factors that can cause this are basically the times when our bodies go through the biggest changes during pregnancy, after childbirth, and then of course in menopause. When a woman is going through menopause, the body changes significantly, and the pelvic floor does take a hit during menopause. So what is the pelvic floor? The pelvic floor is are muscles within the pelvis that work with your abdominal muscles and your diaphragm to basically manage intra-abdominal pressure. They're part of a system that's commonly known as the core. Here you can see the abdominal muscles. This is a special abdominal muscle called the transversus abdominis. It's commonly known as the corset muscle. You have lots of abdominals in your body. This one is the deepest layer of the 4 layers within your body. The diaphragm is your primary breathing muscle. And we're going to talk a little bit about correct breathing today and how breathing correctly can actually help alleviate some of the symptoms of urinary incontinence. The multifidus are muscles of the back. You can't see them on this picture, but they cause segmental movement of the lumbar spine. And it's common that in people with low back pain, those muscles are smaller and not quite as strong as people who don't have low back pain. And then, of course, you have the pelvic floor muscles within your pelvis down here. The pelvic floor has 5 main functions. The first function is support. So the pelvic floor helps to support the pelvic organs, including the uterus, the bladder, and the rectum. It has a sphincteric function, which means that it allows fluids to leave the body, typically through the bowel or through the urethra. They provide stabilization. So they work with some of the other muscles of the body, the core that I indicated in the last slide, to help maintain good posture and to maintain pain-free range of motion. They have a sexual function. In order for orgasm to be achieved, the pelvic floor muscles have to contract for orgasm to be achieved. They also have to relax in order to let the penis insert into the vagina. And then the last function that they have is they manage changes in pressure. So the pelvic floor muscles are really important in maintaining intra-abdominal pressure. This is a picture of the pelvic floor. So let me orient you to this picture. So this here is the front of the pelvis. This here is the spine. This is the urethra, the vagina, and the rectum. This is what the pelvic floor looks like. It's made up of 4 main muscles, okay, with supporting muscles on the outside. One of the things that I think is really cool about the pelvic floor is that these muscles back here, and then this muscle here, are also muscles that are a part of the hip joint. And so a lot of times, if we strengthen the hip and we work on the hip muscles, that can also help improve pelvic floor problems. And many times I'll have patients come to me with a primary hip complaint. And when I start asking them questions, I find out that they do have some type of pelvic floor issue that they're dealing with. And a lot of times we find that when we work on some of these hip muscles, we can also improve some of the functioning of the pelvic floor. You can see that around each of the openings into the pelvis, there are muscles that surround them. So if you look here at the urethra, there's a band of muscles around the urethra. There's also a band of muscles here around the bowel. When we're talking about incontinence, what can happen is that the muscles around the urethra aren't able to maintain tension and contraction good enough. And so when a force is pushed down, those muscles kind of relax and don't allow the urine to stay in. And so one of the things that we try to do when we teach patients, when you try to treat this condition, is we not only try to improve how the pelvic floor is moving, but we also try to improve how quickly these muscles can fire or contract. So let's talk a little bit about what's normal. What is the normal frequency for urinating? Well, typically that is in between 4 to 8 times per day. So anything over that or under that is considered abnormal. How often a person has to go, again, kind of depends on a person's age, but typically every 2 hours is an appropriate amount of time in between voids to have to go to the bathroom. When we're talking about like different times of day, at night, it's more common that if somebody gets up at one time a night to go to the bathroom, that's considered normal, but more than that is not considered normal. And so we'll talk about ways that if you're noticing that you're going to the bathroom a lot during the day, or there's certain things that trigger some of your tendencies to have to go to the bathroom, we'll talk about ways that you can mitigate some of those. Some common habits that people have that can contribute to urinary incontinence include waiting too long. They kind of call this like the nurse bladder. Nurses are very common for not going to the bathroom all day long. And so a lot of times that it can increase tension within the pelvic floor, which can irritate the bladder. And then it can cause urinary incontinence or urge incontinence to occur. Hovering over the toilet. So that's, I know sometimes it's gross to think about sitting on a public toilet, but one of the reasons why we sit down fully on a toilet is because it allows our pelvic floor muscles to relax so that we can fully empty our bladder. And so I would encourage you that if you are squatting at the toilet to stop doing that, because that can cause increased tension in the pelvic floor, which then can lead to increased issues with urinary incontinence. Bearing down to initiate or complete urination, I like to call this power peeing. Again, the muscles have to relax in order to allow urine to flow out. And so if you're pushing out your urine and actively contracting those muscles, you're doing exactly opposite of what the muscles need to do, and that's going to contribute to incontinence symptoms. A lot of times people feel rushed to go to the bathroom, so they may not fully empty the bladder. And what that can do is it can kind of get that communication between your brain and your bladder. It can kind of throw it off a little bit. And so then when you go to the bathroom, your body thinks that you're done. But then when you go to stand up about 5 minutes later, you have to go to the bathroom again because you actually didn't fully empty your bladder. So make sure that when you are going to the bathroom, you're fully emptying it. This is a common one when we go on long road trips, voiding just in case. Again, I encourage you to, use that natural sense that your brain has for when your bladder is full and go to the bathroom when you actually have the urge. Your body can ignore urges up to about 400 milliliters of a full bladder. Higher than that, especially around 600 milliliters, that's when you start to get the urge, the cue that you urgently have to go to the bathroom. And so if you're noticing that when your bladder is a lot less empty, it means that kind of those signaling between the brain and the bladder is a little bit off. And then of course, we always encourage wiping the correct direction, front to back instead of back to front. Urinary incontinence definition is a complaint of an involuntary loss of urine. There's 3 common types that we're going to talk about today. One of them is stress incontinence, which I talked about earlier. It's loss of urine with physical exertion. And this commonly affects the function of the pelvic floor that is in charge of intra-abdominal pressure. So when you have a physical exertion, you do have an increased amount of pressure that goes down onto your pelvic floor. And that can cause stress incontinence because the bladder can't hold, or the urethra can't hold that contraction. The next one is urgency incontinence. And this is a loss of urine when you have the urge to go to the bathroom. You can kind of, if you ever watch television, there's the, you gotta go right now commercials. That's an example of urge incontinence. And a lot of times that is an issue with the communication between the brain and the bladder. The bladder has certain special cells on it that provides a feedback loop to the brain to tell the brain when it's time to go to the bathroom. And the brain has the power to either suppress the urge or to increase the urge. And so our goal is to try to make that more as normalized as possible. And then finally, mixed incontinence is a combination of both of these, stress and urge incontinence. The causes of urinary incontinence, especially urge incontinence, can be caused from tight pelvic floor muscles, which then lead to increased urination. However, this can also happen during stress incontinence. So when I say tight pelvic floor muscles, what do I mean by that? So like all muscles in the body, the pelvic floor has to move through a range of motion. So think about your biceps, okay? Straighten out your arm and bend your arm and do that back and forth, almost like you're flexing. So your biceps muscle has to move through a full range of motion for you to be able to pick something up, to reach above your head, right? Your pelvic floor muscles are the exact same thing. They need to be able to lift up to provide more support and drop down to provide less support. And what we find in these patients that come in is that a lot of times their pelvic floor muscles are not able to move through their full range of motion, or they're stuck in a more contracted state in the kind of the middle range of their range of motion. And so one of the things that we try to do is try to help improve the range of motion of these muscles. When we're talking about urgent continence, there are certain triggers that can cause those symptoms to increase and can feed into the tightness within the pelvic floor. And that includes running water, or, let's say you go to the bathroom every time you get home. Your brain is used to that. So once you put your key in the door of your lock, you all of a sudden have the urge to go to the bathroom, or something like seeing a toilet. So these are all basically objects that your brain has associated with going to the bathroom. And so it'll send that signal to your bladder saying that you have the urge to go to the bathroom. So this is a diagram that just basically talks a little bit about what stress incontinence is, just like a visual view of it. So in stress incontinence, when the bladder is full and something basically pushes down on the bladder, let's say you cough or you laugh, instead of this urethra being closed, that forces the urethra to open. And so then that can cause small amounts of urine to be passed. And this can be caused by a combination of weakness within the pelvic floor muscles, but also, again, some of that tightness. Because again, if your pelvic floor muscles can't move through their full range of motion, then they're not going to be strong throughout the entire range of motion. This is another diagram that basically looks at kind of how the bladder fills and empties. So as the bladder fills, the bladder muscles, the ones that we don't have control over, basically start to relax to allow the bladder to expand. And as the bladder continues to expand, that's when it sends a signal to the brain saying, hey, we got to go to the bathroom pretty soon. And, once the bladder is about half full, a person is able to ignore those urges. But once the bladder becomes relatively full, that's when we're not necessarily able to hold that in as much. And so that's when we start to voluntarily think about, okay, we need to go to the bathroom. Once we voluntarily initiate urination, then the bladder muscles here contract to allow the bladder to fill out, and the sphincter muscles of the urethra, those ones relax, allowing the urine to flow. So we talked a little bit about about some of these tips, but when we're talking about urgent continence, we want to, again, retrain our brain, because that's what leads to one of the reasons that leads to urgent continence. So we want to avoid just in case peeing. So making sure that we're not just going to the bathroom because it's going to be an inconvenient time later. We want to make sure that we're drinking plenty of water. I think a lot of times people think that the less water they drink, the less they'll have to go to the bathroom. But really what that does when you're not getting enough water is it increases the acidity of your urine. And acidic urine is a bladder irritant, which means it can actually feed into your urgent continence. And so you want to make sure that you're drinking plenty of water. And when I say plenty of water, how you can kind of check the color of your urine is it should be a pale yellow color. That's when you know that your urine is a good pH or a good acidity or basic level. If going to the bathroom during the middle of the night is an issue for you, then you would want to stop drinking water about 2 hours before you go to bed so that you don't have to get up in the middle of the night to go to the bathroom. Your diet has a lot to do with your bathroom habits, surprisingly. So there are certain foods and beverages that can cause irritation to the bladder as well and cause those detrusor muscles to want to contract and allow urine to flow out. Those include caffeine, so coffee, chocolate, alcohol, carbonated drinks, and then spicy or acidic foods. So we have a lot of Italians that come to our clinic, and a lot of them are eating lots of tomatoes. And that's a food, for example, that has a lot of acidity in it, and it can actually worsen bladder symptoms. So just think about kind of what you're eating, maybe keep a diary to kind of track if anything that you're eating is feeding into some of your bladder issues. You can also keep a bladder diary to see how often you're urinating during the day, to see if maybe you're giving into any of these urges so that you can retrain the brain. And that's going to help you stop and resist some of those urges. It's not an overnight thing. It doesn't happen overnight. It takes practice, just like with anything that's new behavior-wise. But if you give it a few weeks, you should start to notice some changes if you're doing it correctly. So if you do get the urge to go to the bathroom, there's a couple steps that you can take to help retrain the brain. So first, when the urge occurs, you want to stop what you're doing and either sit down or stand still. I do encourage people to not sit with their knees together or to stand with their feet together, kind of like little kids do when they have to go to the bathroom and during their day. And the reason that is because that feeds into pelvic floor tension, which then can irritate the bladder. So when you're sitting around just at your desk or right here in this talk, how many of you are sitting with your legs crossed? How many of you are sitting in the ladylike position with your knees together? I know it's not normal for us to sit with our knees apart, but that's maybe what's feeding into all of our female problems is keeping our knees together. Really focus on trying to let those muscles stretch out. So once the urge occurs, stop what you're doing, sit down, stand still, don't rush to the bathroom, perform a series of urge suppression techniques and remain calm. Some urge suppression techniques you can practice, which we'll practice today, are diaphragmatic breathing. That's one of them. And then you can also perform a pelvic floor muscle contraction, or commonly known as a Kegel, to try to kind of help downplay and tell the bladder you're not ready to go to the bathroom yet. Try to relax and rest your body, perform some deep breathing, think about something else. When the urge starts to subside or has subsided, then you can go to the bathroom. So it's not like you're waiting a long time. You're just waiting a couple minutes to let the urge pass and going to the bathroom after that so that you're not feeding into that feedback loop. Some exercises that I like to commonly prescribe to my patient to help with urinary incontinence. My favorite one is diaphragmatic breathing, which I'll show you on the video how to properly perform that. Pelvic floor stretches like happy baby and child's pose, which I put pictures here. These are pelvic floor stretches, and they're really good for helping to improve relaxation of the pelvic floor and to stretch the pelvic floor. Bridging, Kegels, or pelvic floor contractions. A lot of times people don't perform these correctly, and the main issue is they're not moving their pelvic floor through its full range of motion. And that's where the issues with performing Kegels can be. So making sure that you are performing them through full range of motion and performing them correctly. Squatting is a great way to strengthen the pelvic floor. Walking, and then of course, core activation exercises. So the first exercise that we're going to talk about today is pelvic stabilization exercises. And this is an exercise that helps to engage and isolate the transversus abdominis. So I'll just kind of talk you through this, and then maybe at the end I'll demonstrate these exercises. So with this one, you're going to lie on your back with your knees bent. You're going to put your fingertips on top of your pelvic bones. You're going to slowly exhale while you pull, basically take the tummy muscles and pull them into your spine. And then you're going to inhale, and then you're going to exhale as you fall, as if fogging a mirror, and feel the tummy muscles pull inward. So I'll demonstrate that for you. You can make it easier or harder by changing the positions, or you can add leg or arm movements to make it more difficult. The next exercise that I like to give my patients is diaphragmatic breathing. This one's probably one of the first ones that I'll typically teach, and this engages the diaphragm, the transversus abdominis, and the pelvic floor. It helps improve pelvic floor range of motion, intra-abdominal pressure, And the thing I really like about it is you don't even have to think about your pelvic floor when you're doing this exercise. As long as you focus on your breathing, your pelvic floor is moving. So this one, you'll put one hand on your chest and one hand on your belly. You're going to try to keep the hand on your chest still. Take a deep breath through your nose and let your belly move into your hand. So your belly is going to basically move outward. As you exhale out of your mouth, your belly is going to move back to the normal position. You can perform this in any position. And then you can add different pelvic floor relaxation exercises to help promote pelvic floor movement. Of course, the pelvic floor is automatically going to move during this. So I like this one because then people aren't sitting there thinking about their pelvic floor as they do it. The next one the next one that we give patients, if they've been able to improve the range of motion of their pelvic floor, is then we teach them how to properly do a pelvic floor contraction, commonly known as a Kegel. And typically the cue that I give people for this is to lift up the vagina or hold in gas, or like you're going to stop the stream of urine. When you do a proper pelvic floor contraction, what should happen is the pelvic floor should lift and squeeze. A lot of times people will have the lift component, but they won't have the squeeze component, or they'll have the squeeze component, but they won't have the lift component. And then you, of course, want to make sure that you're fully relaxing after you perform this. The other thing people do is that they don't allow the muscle to return to its relaxed stage, and then you're not getting that pelvic floor to go through its full range of motion. So let me demonstrate those really quick to you. I'm going to just stop sharing my screen here. Okay, and I'm going to show you first the diaphragmatic breathing. Okay, so basically you're going to put one hand on your chest and one hand on your belly. Okay, you're going to take a deep breath in through your nose and then out through your mouth. When you see me do this, I want you to see that I want you to notice what my chest hand is doing and what my belly hand is doing. Okay, so here I go. So notice how my hand on my belly is kind of moving forward and backwards. That's what you want to see. You don't want to see this. Notice how you're seeing my chest hand move more than my belly hand. When you're breathing with your chest hand, you're using more of your neck muscles and your intercostal muscles, which are muscles on your ribs, to do to move the rib cage. You're not isolating the diaphragm. And in order for that intra-abdominal pressure system to work correctly and to have the pelvic floor move through its range of motion, you need to make sure you're breathing from the diaphragm. So that's the first one. The second one is a transversus abdominis contraction. And I'm going to show you this in sitting as well, but typically I'll teach this first to somebody while they're lying on their back, okay? And so basically what you want to do, it's kind of hard to see with my shirt here, but you want to basically touch the hip bones in the front of your hips. So these are my two big hip bones, okay? And what you're going to practice doing, you can also palpate kind of right below your rib cage here too. So you can kind of palpate here. And if you feel in between the rib cage and the hip bones at this bundle of muscles here, and you cough, you'll kind of feel muscles kind of come into your hands. That's your transversus abdominis that you're feeling, okay? When you contract it, you want to focus on taking your belly button and bringing it into your spine. So notice how when I contracted those muscles, my hand moved in. It's almost like you're sucking it in, okay? And trying to contract that. To add the breathing to it, you're going to contract that muscle when you blow out of your mouth, like you're blowing out a birthday candle. So notice how my belly came in. And just like with the diaphragmatic breathing, what's happening is as you're adding in that breath, you're helping the pelvic floor move. Okay, I'm going to start sharing my screen again here. Okay, let me just make sure I got the exercises. As far as like the Kegel, that one is a hard one for me to demonstrate on camera. If you are doing a Kegel and you don't know if you're doing a Kegel correctly, you probably aren't. And if that's something that you want to work on, I highly recommend seeing a pelvic floor physical therapist. I think Kegels are overprescribed by most physical therapists who don't specialize in pelvic floor dysfunction. And here at our office, we actually have a biofeedback machine that we can put on the external, the skin of the pelvic floor muscles and help people understand how their pelvic floor muscles are working. And we're using auditory and visual feedback to try to see what the pelvic floor muscles are doing. So how can a physical therapist help with these problems? What do we do when you come to see us for something like this? Well, we do an individual examination, a movement-based exam, where we take a look at how you're moving. And based off what you're telling us in a history on kind of how this problem is affecting you, we pay special attention to what you tell us and try to see if it matches up with what we see. When we do our exam, we basically find things that we can work on. And based off the things that we feel that you can work on, we create an individualized treatment plan for you. And this can include interventions like manual therapy. And manual therapy is something that involves improving how the soft tissue is moving, basically using our hands to help the soft tissue move better, the joints to move better, trying to improve the coordination of the muscles, trying to make sure that we're prescribing proper exercises so that we're not feeding into problems, improving posture that could be feeding into issues throughout the day, and giving you an individualized exercise plan that you can follow to try to decrease your symptoms. We treat muscle and joint pain, recurring injuries, imbalance, immobility, incontinence, pelvic problems. There's a lot of different things that you can come see a physical therapist for. We do have direct access in the state of Connecticut, which means that for many insurances, unless you're Medicare, many insurances don't require you to have a physician's referral to come and see a physical therapist. You can ask, if you're interested in that, you can call the office that's closest to you and ask the person at the front desk. They'll definitely be able to answer that question. So this just talks more about direct access. And I will say that, it used to be that women didn't really come to see a physical therapist post-birth, but now the American College of Obstetricians and Gynecologists put in their clinical practice guidelines that the 4th trimester, or after a baby is born, all women should be referred to pelvic floor physical therapy so that they can get the proper treatment that they need. Also, women who undergo cesarean sections, which are very invasive and major abdominal surgeries, just like anybody else that gets a surgery within a hospital system, should be receiving physical therapy as well. If you have any questions, feel free to email me. If you're not sure where to start, I'm always happy to help you understand if maybe physical therapy is something that you would benefit from. I highly encourage that if you are having pelvic floor issues, to see a pelvic floor specialist and not just any physical therapist, because again, a lot of times Kegels are kind of everybody's go-to, and that may not necessarily be the right thing for you at this time. It's something that we want to work up to and not necessarily start your treatment at for some people, not for everything. Again, physical therapists individualize their plan of care for the people that they're seeing. So every patient is different. If you have any other questions about our company, you can visit our website or you can call one of our clinics today. And I'd be happy to take questions over email, and thanks for listening today.